You're tuning in to the O&P Check-in, an SPS podcast. I'm Brendan Erickson, a regional sales manager at SPS.
And my name is Jackie Green, a marketing specialist at SPS. This show brings you the latest happenings in the O&P industry. We're unpacking trends and news from this tight-knit orthotics and prosthetics community.
Thank you for joining us. Let's get started.
Thank you to everyone who attended our prior 4 clinical education days. Special thank you to Click Medical, Cypress Adaptive, Extremity, and Bulldog Tools for their informative and fun presentations. Wondering when you can attend the next one? Join us September 28th in Anaheim, California, or December 7th in Alpharetta, Georgia. Earn up to 9.5 CEU credits while networking with other O&P professionals. You can find more information on our website, spsco.com, under the Resource tab by clicking Clinical Services. You can also follow the link in our show notes. We hope to see you there.
Today I am pleased to welcome Dr. Bryan Loeffler, a dual fellowship-trained surgeon at OrthoCarolina. Specializing in the entire spectrum of hand and upper extremity disorders, Dr. Loeffler has experience in complex elbow conditions and peripheral nerve injuries. We're excited to chat with him today about the Starfish procedure, a groundbreaking targeted muscle reinnervation surgery to help partial hand amputees regain individual digit control of a prosthetic device. With that said, welcome Dr. Loeffler. We're so happy to have you.
Thank you, Brennan. Happy to be on with you guys and share some experience with what I find to be an incredibly rewarding field and patient population to take care of.
Absolutely. We're really excited to have you, and thank you so much for your time. I know you're incredibly busy. But for O&P professionals who may be new to the industry or just don't know about some of these upper extremity remedies, what is a targeted muscle reinnervation, also known as TMR?
Great question. So targeted muscle reinnervation is a procedure that was originally described at Northwestern University, and it was really a breakthrough procedure for the management of nerve problems for amputees. So it can take care of things like phantom limb pain, pain within the residual limb. It can prevent or treat neuromas from forming, which are these painful nerve balls that can be really hypersensitive hotspots on a patient who's had an amputation at the end of the nerve. But then what the procedure can also do is help to control myoelectric prosthetics. So targeted muscle reinnervation, to break it down, by the terminology and the words in the title, targeted means that we're taking a nerve and we're finding a muscle that we're going to target it to. So we take a nerve that's been cut who no longer has a purpose and no longer has a muscle to activate in an amputee. And then we take that nerve and we put it into a different muscle. So we reassign the nerve into the new muscle. And we actually remove the normal activation of that muscle that's left in the residual arm. So now the muscle gets activated by the nerve that was previously cut. So to give an example, let's say someone has had an amputation at the level of the forearm. And when they think to close their hand or grip, their brain still thinks the action, still goes down the spinal cord, still goes down the arm, but then it's kind of a dead end. It's kind of where you have a live wire where the nerve isn't connected to anything. But if we take the nerve that's responsible for closing the hand and we reassign it to one of the other muscles in the arm, and it doesn't really matter which muscle it is, now that muscle can serve as what we call a biologic amplifier. So it can take the message from the impulse of that nerve firing and cause a muscle to contract. And when a muscle contracts, that signal can be detected by a surface electrode or something that's placed on the skin that can say, this patient wants to close their hand. And that's why this muscle's firing. And so when the electrode gets that impulse, it can then send a message to the bionic hand or the robotic hand that makes the hand close. So that kind of simplifies how TMR allows us to take a nerve that no longer has a purpose and can cause all kinds of problems because it's kind of a dead-end live wire. And we can then harness that signal with a muscle that's still there in the arm, take care of phantom limb pains, and prevent these neuromas from forming. But we can also use that signal to control a prosthetic in a way that's very intuitive for patients, meaning that there's not a lot of training involved. So the person just thinks, close my hand, that nerve fires, the muscle contracts, and then the prosthetic hand closes. So that has been a real breakthrough in the management of these patients that has helped with the pain issues, but has also helped tremendously with control of these prosthetics, and it's improved the utilization of these prosthetics as well, and has made the training process for using these prosthetics much more easy, much easier, much more facile.
Wow. The fact that it's easier for them to use it, do you know if that helps with the adoption of the prosthetic? Because I know in other interviews we've had, they find that sometimes it's very difficult to get patients to use them or really want to use them because there is such a sharp learning curve in the beginning.
Yes, that's a great question and great point. And that's one thing we've really noticed is that this procedure has made it a lot easier to transition. It's a lot more natural. So when we take care of a patient who's an amputee, we tend to do the TMR at the time of the amputation or very shortly after an amputation when we're able to, when we see the patient in that time frame. And we say we're setting them up for success. So we rewire them, by taking their nerves and plugging them into different muscles to set them up so that if and when they do get a prosthesis like this, that they can control it easily. And we found the usage rates are just much higher than they were in the past. So it's a great question. I mean, I look at what we're doing as making innovations on the surgical side to try to match technological improvements. So we're trying to improve the connection between the human being and the machine through what we're doing surgically. And, it makes a huge difference. A lot of people will get really frustrated or, in the case of an arm amputation, they may just learn to do everything with one hand. They may just say, forget it, I'm just going to use whatever I have left on my arm, and I'm too frustrated with this device. I can't control it. I'm having to bend my wrist to get my hand to close or think of extending my wrist to get my fingers to open. Or for, prosthetic digits, I can only get them all to come down as one. Whereas with some of the surgeries we're doing now, you can get the fingers to come down individually. So it's really exciting to see how easily patients, literally for the first time that they ever get a device, sometimes they can put it on and just put it to use right away.
So can you explain a little bit more about how you and your colleague, Dr. Glenn Gaston, pioneered a new TMR procedure?
Yes. So we have taken the original principles from the original descriptions, from the work that was done at Northwestern, which originally was TMR procedure for shoulder level disarticulation. So really taking the nerves and putting them into muscles in the chest to control a prosthetic. And they experienced success with that, and that was then implemented into levels going down the arm. So through the middle of the arm, through the forearm, and even into the hand. And so we've just adopted, those original principles and applied them in some different ways for people at the level of the arm. And in the forearm, we have different algorithms and different targets that we will use, different strategies for what nerve goes where and how we do it. That has kind of evolved over the last several years. And we're in a new space, so we're learning. Our patients are teaching us based on their results, the kind of pain management that they achieve through this, the control that they get, the way the limb gets back to its normal volume so it can fit a prosthesis, etc. We're keeping a very close eye on those things and learning and refining our techniques. And we had kind of an interesting and unique contribution to the prosthetic field a few years ago when we developed something called the Starfish procedure. So the Starfish procedure is for patients with a partial hand amputation. So patients who have lost the fingers of the hand. Could be a couple fingers, could be all the fingers. The reason we kind of came up with it was we were inspired by our patients. We were seeing how much trouble these patients were having after these devastating injuries where they lost the fingers in the hand. And the traditional prosthetics would give them some improvement in function, but again, utilization rates were quite low. They were quite limited. Patients were being taught to try to kind of cross their fingers or spread their fingers out wide to generate enough of a muscle signal that it would cause the electric digits to close and open. Or they'd have to put sensors on the forearm level, which was quite cumbersome. If you have a prosthetic hand on and then it has to go across the wrist and even go to the forearm to control it, that can get kind of frustrating. And so patients weren't doing very well with that. So what we thought is, in patients who've had an amputation of their fingers, they still have muscles deep within the hand, within the palm, that go to those fingers. And those muscles contract when a patient wants to move the finger. It's just you can't detect the signals very well because they're buried in the hand. They're in between the metacarpal bones. And so surface electrodes can't really pick up on them. And the muscles that we're talking about are called the interosseous muscles, or even the lumbrical muscles that are they're intrinsic muscles in the hand. They're muscles that reside within the hand. And they're traditionally thought of as muscles that spread the fingers apart and bring them together and do sort of fine dexterity. But they also contract when a patient wants to open and close the hand. So our thought was, could we take those muscles that live deep within the palm, between the metacarpal bones, and release them from their native attachments where they normally attach on the bone there, and keep their nerve and blood supply, but then move them up directly underneath of the skin so that we could take one muscle right under the skin with one surface electrode directly over that muscle that could capture the signal from the muscle contracting that would then be set up to a prosthetic digit. And could we do that for each one of the fingers so that the person could just think, move my index finger, move my middle finger ring, etc., and each one of those muscle contractions would translate to a myoelectric or electric digit doing the same thing. And so we kind of had this idea. It was kind of in the surgeon's lounge, literally, drawn on the back of a napkin, kind of brainstorming, talking back and forth when we had just been taking care of a patient that had this injury. And we went to the lab and we said, look, we can't find this in any textbooks. It's not written about exactly where those nerve innervations come into the muscle and exactly where is the blood supply to these muscles. How much can we really move it to do what we wanted to do? So we studied it in a cadaveric setting, which means on a donor's hand, and we even did staining of the blood vessels where we injected the vessels to see exactly where the main blood supply to those muscles were and where the nerve points came in. And the nerves are tiny at that level, but we learned that we could actually take the muscle and move it without disrupting the normal nerve and blood supply go into that muscle. And we could put it right underneath the skin. So we kind of had a proof of concept there from our laboratory work, and we had a patient who'd had a multi-finger amputation, and we told him about it. We said, we think we can save that muscle, we can move it under the skin, we can keep it alive, and we can keep its normal nerve activation of it. And we think this will allow us to put an electric prosthesis on there that will allow you to move individual fingers without having to think anything other than bending and straightening each one of those individual fingers. So phase 2 was doing it on that first patient. So that first patient knew, that this was kind of an experimental thing. But fortunately, we weren't going to really lose anything. If it didn't work, it didn't work. But it didn't add a tremendous amount of time to the operation without really much in the way of additional risk incurred there. So within 2 weeks of the surgery, we could see the little muscle bulges where we'd done all the muscle transfers. And we were able, in a benchtop setting, to put sensors over each of the muscles and just see on a graph, can we see electrical activity when the patient wants to move that finger? And it actually worked. It worked immediately. So we were absolutely thrilled about that. And then it was a matter of collaborating with our prosthetic colleagues who were able to take the technology that's out there, the individual digits, with the controller and a processor for that, put it in housing, put it on a hand that fit nicely on the hand, and actually get them to do that. And so we had to get funding as well to do this, because obviously it wasn't covered by insurance and it's not inexpensive. But the OrthoCarolina Research Institute supported the first prosthetic hand that we created for the Starfish procedure. And we did a prototype of it, which again was kind of at a benchtop, setting. But the patient, the first time he got hooked up to it, it was 100% successful and accurate in controlling the individual digits. And then it was just a matter of creating a custom prosthetic with each one of those individual digits in that housing with that controller to get it to work. And the patient put it on and just was instantly able to move each of the fingers with complete control for opening and closing individually, which was a huge breakthrough. And I mean, it was incredible just to see an idea, really come to life. I think it took about a year or so from inception to actually doing it on the first patient. But now we've had the opportunity to do it in about 30 patients, and it's worked every time in terms of the ability to create that signal. And we've trained a lot of other surgeons who've come to visit or heard our lectures or seen us do the procedure, and other surgeons have had success with it as well. It requires collaboration with very competent and dedicated prosthetists to put it all together and make it work. But it can be life-changing, really.
Okay, so you mentioned the name Starfish. Can you just tell us how you came up with the name?
Yeah, so that's a good question. When we were in the lab, we wanted to think about how could we, once we figured we could do it for each of the fingers, how could we do it on an even bigger scale? Would we actually be able to do it if somebody lost the whole hand? Would there be a scenario where we could do that? And essentially, if the muscles are there and they still have the nerve and blood supply, regardless of what's happened to the tendons, the ligaments, the bones, if we can save those muscles, we could even put them up in the forearm if we needed to, as long as we can keep the blood supply and the nerve intact, each of those muscles, then we could still do the same thing. So when we did that, when we took the donor's wrist level, but we saved all the muscles and we reflected it back, each of the muscles went in different directions. It looked like a star. So I said, oh, that looks like a starfish. And then I was thinking about it. I was like, the starfish is renowned for its unique ability to regenerate a limb. So it seemed like the perfect name for it. So that's where it came from.
So what's next for the Starfish procedure? What do you kind of see on the horizon for future development?
Well, I think being able to spread it so that more surgeons are facile, are able to do it, reaching more patients. That's certainly one thing. And, marrying that with a prosthesis that's kind of off the shelf is something that we have been working on for the last few years. Because, to date, it's been kind of a custom, for each one of the patients. So if we can make that process easier, I think that'll allow the procedure to be more widespread. So that's one avenue. There's two other thoughts that we have, one of which we've done already, and it's, again, setting someone up for success, even if the technology is not quite there yet. So as I mentioned in the lab, one of our thoughts was, let's say the hand's mangled, but you still have good muscle, and you can save that. So you put it up in the forearm. Even if you did an amputation through the forearm, through the wrist or the forearm level, but if those muscles are still there, they still go to the individual fingers. And they're still going to have a signal that can control a prosthetic. So if we can get to the point where we have a forearm-level prosthetic that has the capability for individual digital control, then we could still use those muscles to do the exact same thing for the thumb, as well as the individual digits. So we've had a couple patients that were in that scenario where they had mangled fingers, but we were able to save the muscles, and they actually would do much better with a forearm level amputation because of their injury pattern, etc. But we saved the muscles, so they're set up for that. And I think we'll have other patients as well. But that's kind of applying the same concept of salvaging the muscles that already have nerve and blood supply to them to harness those signals to control prosthetic. And to take it one step further, and again, we haven't had the patient for it, but if we had a patient whose limb was completely severed, but we got access to the hand, and the hand was not damaged, even if a reimplantation was not possible just due to the nature of the injury, there was a long segment of artery, nerve, bone, tendon, etc. loss where you couldn't put the whole arm back on, but you had the hand. If you could take the big blood vessel that goes to those muscles, the nerve that goes to those muscles, and repair that to the nerve all the way up at the level of the injury, even if it was up in the arm, then you could actually keep the muscles alive, and you could get the nerve that's still working, that's still intact in the residual part of the arm, to activate those muscles. So the concept is called a free starfish. So it would be basically taking that whole, it's taking the muscles within the hand and transplanting them up into the arm, so you'd be able to control a prosthetic. Now, again, the technology's not quite there yet to have a prosthesis that has those capabilities. But if we had that patient that wasn't amenable to doing a reimplantation and the hand was still in good condition, we could do that as well.
So you talk about, having these patients presented to you or these situations presented to you. Can you tell us a little bit about who would be a good candidate for each of these levels, and also touch on the time frame? If somebody had an amputation 5 years ago, are they able to do this now, or does it need to be at the moment of trauma where you guys come in and do this?
Yeah, those are excellent questions. So, as long as the amputation is within the hand, probably about the mid-metacarpal level, maybe even slightly closer to the wrist than that, proximal to that, that's kind of where the nerve and blood supply comes into those muscles. So as long as there's still muscle there that has the native innervation, which is the nerve supply and the blood supply to it, we can do the procedure for them. Patients who've only lost one digit, this is not going to be a game changer for them. So we've done it on patients with 2 to 4 fingers at a level that is somewhere between the PIP joint and the midpoint of the hand. So the PIP joint is kind of that first knuckle of the finger. If we can save that much, especially if the patient has a good thumb, then there are other prosthetic options available, and they still have their native MP motion, so metacarpal phalangeal motion, kind of where the fingers meet the hand. If they still have that, there are other prosthetics that don't require any electric components that can work well. So as long as the finger is long enough, once the amputation has been carried out, that it can fit a ring on it, that's usually long enough that a traditional prosthetics can work. If it's too short to fit a ring, or it's all the way down to the mid portion of the hand, those are, with 2 or more fingers, those are the ideal candidates for starfish. And we've seen many, many different types of injury mechanisms that led to this. So we've had patients who had, traumatic injury to it. We've had patients who had something called vasopressor-induced gangrene, which is essentially where they're in septic shock and they go on medications that keep the person alive, but the sacrifice is that it cuts off the blood supply to the end of the fingers, causes the fingers to get lost. We've done starfish on those patients. We've had anywhere from 2 to 4 fingers. We've had some other interesting and unique mechanisms that led to the same sort of endpoint that we've done it for. And what's nice about it is it really can be done anytime. So, and ideally, when we see somebody, we try to do it as close to the time of injury as possible, just because we want to get that healing process underway. We want to get the soft tissue swelling down so that we can get them fit for the prosthesis, get them using that prosthesis, make sure they don't default to a one-hand, one-arm mindset and pattern of activity. We want to keep them using it as soon as possible. But even for patients who are years out from injury, who have struggled with the traditional prosthesis, we've been able to do the procedure and it's worked well. And they've used the prosthetics in a lot of those cases. So that's the nice thing about the timing of it, is really there's no pressure. We like to do it sooner if possible, but we really can do it at any time. I would say at most a third of the patients that we've done this on are patients who are sort of local or regional that we've done in that acute time frame. A third of them are referred to us within a 1 to 6 month time frame. And then maybe a third of them are years out. So again, that's kind of the different mechanisms that people have come in through, and it's worked well in all those different time settings.
Is there any chance somebody that had a congenital, maybe issue going on, that they could receive this if they had the hand intact?
I love that question. So I'll tell you our experience with that. There's a not common, but it's a little more common in our world because of what we do. But patients who've had a congenital arrest in the forearm, or something called symbrachydactyly, affecting the forearm, it kind of traditionally happens kind of in the proximal third of the forearm, or kind of close to the elbow, but not all the way at the elbow. We asked the question, could these patients control myoelectric prosthetics even though they never had a hand? Would they have the wiring to do it? And so we took a cohort of our patients who'd had that, because we wanted to see, do we need to do TMR for these patients to give them better control, or can they somehow do it anyway? And what was amazing is the patients that had a congenital amputation of the forearm were able to control the myoelectric prosthetics as well on the arm that was born with the absence of limb, as well as they were able to do it on the other side. When we hooked up the same sensors on their normal arm, they had just as good a control on the side that was born without the hand. So the patients really are already wired for success there, and they don't tend to deal with, when you're born without a limb, you don't tend to have pain associated with it at all. So those patients, we learned, they actually don't need any surgical intervention.
What should our listeners do if they think might be a really good candidate for this procedure?
Well, I think the first thing they can do is reach out to their orthotist and prosthetist, their CPO, and tell them they've heard about it and checking it out. They could talk to their surgeon as well if they have a relationship with a surgeon. One thing I would say is, traditionally a lot of these patients kind of undergo their amputation, then they get passed off from the surgeon to their prosthetist or the rehab physician who's a non-surgeon. And so the patient doesn't necessarily maintain that relationship with the surgeon. That's been a fundamental change for us too, because we're linked to these patients for life, and we want to take care of them throughout the entire journey. As I mentioned before, I've learned so much, from the patients, and that longitudinal relationship has allowed us to fine-tune things in a way that, makes us better able to achieve the stated goals. So in our case, there's a close relationship that's ongoing between the patient and the surgeon. But if the patient doesn't have that ongoing relationship, or it's been some time has passed since they were taken care of by the surgeon, they can reach out to us directly. If they're interested in learning more about it, we have a website. So the name of our multidisciplinary clinic for taking care of amputees in Charlotte at OrthoCarolina is called the OrthoCarolina Reconstructive Center for Lost Limbs. So if you Google OrthoCarolina Reconstructive Center for Lost Limbs, it'll come to the page, which has some information on it about the clinic, about the services that we provide, the multidisciplinary team. There's some sort of patient testimonials or patients that have had the experience that can share. And it's a way to kind of get familiar with what we're doing. We also have an email address that we set up for patients that have inquiries. And it's just amputee@orthocarolina.com. So if patients want to learn more, if they want to set up a virtual visit to learn more about it, if they want to just correspond over email, or if they want to do an in-person visit, that's the first way. We try to make that as seamless as possible, so patients can just email the amputee@orthocarolina.com email address. So those are the main ways to connect and to learn more about it and see if you're a candidate for it, if it's something that's worthwhile. And I will say too, we really look at each person individually and from a unique perspective. So not every person who has partial hand amputation needs to have Starfish. And not every patient who's had an amputation throughout the arm needs a myoelectric arm. In fact, we have many patients who have body-powered prosthetics, or they have task-specific terminal end devices, that they use. And we really try to tailor our treatment to the individual's needs and requirements. So it's not a one-size-fits-all type of mentality.
Well, I think you guys are doing tremendous work, and it seems like you guys are in it for the long run. I love your attitude. I mean, just even looking forward to the future and setting people up for products that aren't even there. You're just doing an amazing, amazing job. Is there anything you'd like to add that we haven't touched on?
Yeah, well, if you don't mind, I would really like to acknowledge some individuals. Number one, because this, one person obviously does not come up with this type of innovation and do these types of things without tremendous support, without a tremendous team. So, number one is to thank the patients who put their faith and trust in us for taking care of them. My partner, Glenn Gaston, we've talked about, this has been a team-based approach between the two of us since we started along this line. Neither one of us had any expertise or real training in the care of amputees, when we started our practices. And I'm also incredibly thankful for the occupational therapy presence that we have in our clinic at the Reconstructive Center for Lost Limbs at OrthoCarolina. Marcy Siebert is the name of our occupational therapist who, has really taken the greatest interest in this. And she spends a tremendous amount of time with these patients at all phases, in cases where it's pre-amputation or through the process, and in all the rehabilitation, adaptations with their different prosthetic devices. We've had the great fortune to work with some outstanding prosthetists as well. Just to name a few would be Brian Monroe, Stephen Shope, Mark Elgart, and Mike Jenks. And then finally, I would just want to thank Dr. Darcy Alexander. She is a clinical psychologist who's in the clinic with us as well. So I just want to thank the team. And then finally, if you don't mind, I also just wanted to share, we have created an organization, a non-for-profit organization called Arms for All. And if you want to learn more about it, we have a website. Just type in Arms for All. It's FOR, all.org. And it'll show you the organization we've created. So essentially we said, look, there's all these great things out there that can be done for people. We can do them, but a lot of times the patient doesn't have the financial means, or for whatever reason their insurance doesn't cover it. And we really want to be able to provide a prosthesis for every patient who wants one, who's had an amputation. And Arms for All has allowed us to raise money that we've been able to award patients who didn't have the means otherwise with prosthetic devices. We formed this not-for-profit a couple of years ago, and it's growing and growing. And so if anyone has been interested or inspired or enlightened by any of the things we're talking about, I know based on the audience that you all share a passion, of course, for taking care of these patients. Check out the Arms for All.
Yeah, so thank you so much for being here. And everybody, he's due to be in the OR this afternoon, and he took a tremendous amount of his time to be on this podcast. So thank you very much, Dr. Loeffler, and thank you very much to your partner and your entire team, Dr. Gaston, and all the others you mentioned. This is really amazing. Thank you guys so much.
Yeah, thank you.
Thank you both, for the opportunity to share this with you, and I really enjoyed talking to you guys.
Awesome. Well, everybody, if you would like to connect with Dr. Loeffler on LinkedIn or learn more about the work over at OrthoCarolina, or to check out the Arms for All, we will put all of the links in our show notes, and go and check them out there. Thanks, Dr. Loeffler.
Awesome. Thanks so much, Brendan. Thank you, Jackie.
Yeah, no, thank you.
Thank you for tuning in to the O&P Check-in, an SPS podcast.
If you haven't already, be sure to subscribe to the show on Spotify, Apple Podcasts, or wherever you listen to episodes.
And while you're at it, rate and review the podcast to help fellow O&P professionals find us.
Email us your topic suggestions and feedback at spspodcast@spsco.com.
See you next time.